It's a pleasure to be here. And I am so glad that we have so much interest in this webinar. Obviously, it's a very timely topic, and so really excited to have the opportunity to share with you precisely what are the steps towards compliance. I know this is a challenge for long-term care. This is something that really is new for the long-term care community. And so we've spent the last couple of months really parsing through this compliance directive and ensuring that we provide the best, most up-to-date information to you. As Sarah shared, my company is CleanHealth Environmental, and we provide environmental consulting services surrounding worker protection and infection prevention and environmental hygiene. So all of those challenges that we are grappling with in our facilities now. And so as Sarah said, I really do want to allow time for questions at the end. I know that's what generally people want, their questions answered. And so I will do my very best to get through the curriculum in a timely manner and at least leave 10 minutes for questions following. On that note, however, I do have my contact information here that I'm happy to share with you, and we're happy to be a resource if you have any questions following the webinar as well. So let's go ahead and get started. We're gonna really parse through how we got here and then what the OSHA regulation requires, the emergency temporary standard, and then we'll delve into how you comply with that. So first of all, we know that the focus here with OSHA, as it always is, OSHA's sole focus is the employer-employee relationship, and has the employer provided the proper protections for that employee. And so we know that when the new administration took over, soon after an executive order that you see there on your screen, focused on protecting worker health and safety, in particular to COVID, was introduced. And then the guidance that was initially a guidance under the former administration was updated. So that put a little bit more of an oomph on the requirements for worker protection from employers, where they changed having a program in place from a can to a should. And that sounds like semantics, but in the world of regulatory compliance, that's a very big difference. And so that was sort of the beginning of this process of enhancing worker protection surrounding, in particular, COVID-19. A national emphasis program was also initially announced in March of 2021, and then that was yet again updated in July of 2021, just last month. And the emphasis really focused on OSHA enforcement and ensuring that their inspectors, their OSHA inspectors, are focusing on those facilities that are most at high risk in regards to enforcement, and obviously healthcare. Long-term care included is a component of that. So there is a national emphasis, and there was a publication also on enforcement that was published on June 28th that they refer to, and I'll make reference to that as well. So once we had the updated guidance, as many of you I'm sure are aware, there was then the recognition of whether this was going to become a rule or whether it was going to remain a guidance. And that was a little bit of a stall there from the White House at that point. And then on June 21st, they made the announcement that the OSHA emergency temporary standard was going to be implemented, and it needed to be adhered to by only healthcare. So that was pretty contentious, I'll say, from other industries such as the meatpacking plants, for example, and those other types of industries that also have those challenges surrounding transfer of infection. But the administration decided to focus the emergency temporary standard solely on healthcare. And we're going to get into precisely who is covered under healthcare. And then, as I just shared, a directive from OSHA as to how do we enforce this new OSHA emergency temporary standard was published on June 29th. And as we see, there's a significant amount of money that is being allocated towards this enforcement, recognizing that employers are going to need to take a more robust role in protecting their workers. So one of the million-dollar questions that I want to start out with, which is whether the emergency temporary standard applies to your facility. And OSHA does have a plethora of really great resources out there. At the end of my presentation, I did create a resources slide for you all. And a lot of this information is found on the OSHA ETS website, as I referenced there. But in general, the ETS rule applies to healthcare settings where suspected or confirmed COVID-19 patients are treated, including hospitals, nursing homes, and assisted living facilities. Emergency responders and home healthcare workers would also be under this emergency temporary standard. So again, there's a really nice spreadsheet, chart that OSHA has provided, and it allows you to go through to determine whether your specific healthcare facility is covered by the emergency temporary standard. But I did want to parse through this a little bit with you. I know there's been a number of questions, and in general, when they refer to the terminology covered settings, it would be settings where any employee provides healthcare services or healthcare support services. And so when we look at the definition of healthcare services, services provided to individuals by professional healthcare practitioners for the purpose of promoting, maintaining, monitoring, and restoring health. So that would be healthcare services delivered through various means: hospitalization, long-term care, ambulatory care, home health, hospice care, etc. Okay, so very broad terminology, obviously. And when we use the terminology support services, those are the services that facilitate the healthcare, and that, as listed, would include patient intake admission, patient food services, equipment and facility maintenance, housekeeping services, healthcare laundry services, medical waste handling, and medical equipment cleaning and reprocessing. So again, a large, very broad definition of both healthcare services and support services. But one of the questions, and that one that I wanted to follow up with directly, and this was where we had questions about independent living, for example, and whether that is specific. And the answer is it depends, of course. The answer is it depends. So that flow chart that I shared with you is a great resource to go back and to determine the case. But one of the exemptions that I think would potentially be most valuable to this group would be well-defined in any settings where there is no reasonable expectation that any person with suspected or confirmed COVID will be present. Okay, so if you have a well-defined area of your building where there is no reasonable expectation that any person with suspected or confirmed COVID will be present, there are exemptions available. So if that was the case, the emergency temporary standard requirement for PPE, for physical distancing, physical barriers would not apply to those employees who are fully vaccinated. If that's an exemption that you are seeking, employers need to make sure that they've established procedures for determining employee vaccination status, and they must document those procedures in the COVID-19 plan, which is really the core of this emergency temporary standard, and that would need to be a part of it. So that is the primary exemption of focus. That being said, it really is going to be challenging to be able to validate that you have a well-defined area where no expectation of suspected or confirmed COVID will be present. So if you have staff that may be moving back and forth, that would likely take you out of the exemption. If you're performing any specific type of services, healthcare services in an independent living facility, for example, then that would potentially limit that exemption. So it's really a case-by-case basis, but you do want to go through the flow chart that they provide and make that determination. So what are the requirements of the plan? And I just want to go through these, and then obviously I'll take a deeper dive into them. A written formal COVID-19 plan, that again is the core. To write a plan, written formal, if you have 10 or more employees, more than 10 employees under OSHA, it must be a written plan. If you have under 10, then it still must be a plan, but it doesn't need to be written. You must perform a hazard assessment, as I'm going to review. discuss transmission and standard-based precautions, address personal protective equipment and cleaning and disinfection procedures, and of course, conduct training. So these are the requirements of a COVID plan, again, with the ultimate goal of protecting your workers in a healthcare environment. The requirements: continued procedures for aerosol generating. So if that's a circumstance that is arising in your facilities, that will need to be addressed, written in the program. Building ventilation, that's something that we have turned our attention to over the past several months, now that it is confirmed and validated by CDC that ventilation and airborne nature of SARS-CoV-2 is possible. And then we get into the components of the plan surrounding administrative controls. So how are you screening your employees? What sort of vaccination and paid leave protocols do you have in place? Is there language in your plan to assure your employees that there will be no retaliation if they do raise a complaint surrounding COVID-19 protections? And then of course, record keeping and reporting as well. So I'm going to delve into some of these in more detail as we go through the presentation, but this is really the core of this program. So to start off with, like I said, the core, which is developing the COVID-19 plan. And as we just discussed, this plan must be written. And for all of those components that I just went through, there's going to be a significant portion focused on each of these as you put your plan together. So again, we'll go through these each together, but I think it's easy in sort of to figure out how you parse through this regulation, which can be challenging, is to think about it as really 3 buckets of compliance that you need to adhere to. The first bucket is personal protective equipment and all of those protections surrounding transmission-based precautions and standard-based precautions. The second bucket are your engineering controls. What engineering controls are you putting in place? Your situation with your cleaning and disinfection, your ventilation and your changes to your ventilation systems. Those would be all under the engineering control bucket. And then the third bucket is the administrative controls. What sort of screening is being done? If there is a positive case, how do you notify the others in the facility? What are the proper procedures for training, which would be an administrative control? So it's really important and valuable to understand what needs to be in a plan in order for you to know how to develop it. So on that note, I have a poll here that I wanted to launch, and this is all anonymous, so no one's coming to find out how you answered it, but I just really am curious to see whether your facility has a COVID plan. So I'm going to go ahead and launch this poll. And if you would just take a minute to answer it, does your facility have a COVID-19 plan in place? Yes, we have a written infectious disease plan before, and we're utilizing that. Yes, we've created a standalone plan that would say once the pandemic began. 3, we have components of a program, but no COVID specific plan. And D would be we are working on creating the plan. So I'll just give you a minute to fill that in. Interesting. All right, I'll give you about 8 more seconds to fill in the poll. Thank you so much for participating. We got about a 60% participation rate. I appreciate that. And then I can share the information and see how you're doing along with your colleagues here. All right, I'm going to go ahead and end the poll and share the results. And so it looks like, yes, we've created a standalone plan once the pandemic began. It looks to be 55%. You're using a plan that's already in place. And just, I would imagine, tweaking it a bit with COVID in mind. And then you're working on creating the plan about 13%. So really valuable information to know and to where you are in the process. All right, so, and once we know that we have to have a plan in place, the first step is to perform the hazard risk assessment. And yet again, OSHA has a number of great resources to assist with this. This is something as a company that we do. We help long-term care facilities and different healthcare facilities perform these duties. And it can be a little bit overwhelming, but there are procedures and guidance documents in place. So first we perform the hazard risk assessment on each of the different types of folks in your property to determine what their risk level is. So someone working in an office environment clearly may be different than have a different risk associated than an employee that's working in the ventilation, in the vent unit. So clearly we need to determine the potential risk of each employee, assessing different types of engineering and administrative controls to determine the risk of each employee and what they are considered, low, medium, high, or highest. Another important component of the program, as I already reviewed, is personal protective equipment. Obviously, we're all fully aware of that. And so when I talk about PPE, I'm talking about face masks, and I'm also talking about respirators and gloves and all those other components of PPE. So we know that part of your COVID plan, you clearly have your PPE and what is specified. FDA approved face masks must be provided, used properly. You need to document that. There is a face mask exemption, and this is hot off the presses. And again, in a world of COVID where things are fluid, I know you all have challenges with keeping up with things. So my goal is to keep you up to date with what's happening right now, today, with this emergency temporary standard. But in this temporary standard, there is an exception for general mask rules. If you're in a circumstance, as we discussed earlier, where there's fully vaccinated employees in a well-defined area, and there's no reasonable expectation that a person with suspect or confirmed COVID will be present, then the face masking rules can be exempted. Of course, you can always make that business decision to continue with that, but there is an allowance in those limited circumstances. And what's really interesting about this is, as we know, as unfortunately we're entering our fourth wave of this pandemic, a number of states and jurisdictions have rolled back the allowance for fully vaccinated people to not wear masks, right? We see that I'm in Montgomery County, outside of DC. And for example, we are now required even fully vaccinated folks to fully mask indoors, but this exemption still remains. And OSHA did address this particular reference last week and said that despite the fact that there are some jurisdictions that are rolling back, or I say implementing in-house face masks for inside, the OSHA requirement remains the same. They still allow the exception. And their justification for that is that things are fluid, CDC's changing, jurisdictions are changing, and so OSHA doesn't want to just kind of fly by the seat of their pants and change as soon as another does. And so therefore they're keeping that exemption as of today. August 9th is the only thing I can validate where they're still allowing that face mask would not need to be used in those very limited circumstances. So that's face masks. Also part of this emergency temporary standard is what they're calling the mini respiratory protection program. So we know that when we work in a healthcare facility, once someone is in a circumstance where there is suspected or confirmed COVID, where there is aerosol generating procedures being conducted, or standard or transmission-based precautions required, the traditional respiratory protection program applies. And I'm going to go over that in just a minute. In the only circumstance where it's a situation where the employee does not need to wear a respirator, they're not mandated because they don't fall under any of these provisions, but they would like to wear a respirator instead of a face mask, then that's where the mini respiratory protection program comes in play. And as an industrial hygienist, this was really just another recurrence or another way of explaining what we call the voluntary use. Under the traditional respiratory protection standard, Appendix D already had a provision about this, about voluntary use and what would need to be notified and who would need to be notified of that. So this is really taking the voluntary use under the respiratory protection program and creating what they're now defining as a mini respiratory protection program. So in the circumstances, again, where there's no OSHA mandate to wear a respirator, then you can implement a mini respiratory protection program. And this mini respiratory protection program, again, this is where folks are wearing a respirator, an N95 generally, in lieu of a face mask. Then they would still need to have the user seal check. There would still need to be proper training. So regardless of whether you're providing the mask or they are, I'm sorry, the respirator or they are, you would need to fall under these program elements. Now, as we talked about, if you're in a circumstance where there's confirmed or suspected COVID, where you have aerosol generating procedures or standard or transmission-based precautions, then the full respiratory protection standard will apply. And this, again, is somewhat new to the long-term care community. We've been very busy working with communities with creating the respiratory protection program. Again, it needs to be a written program. And then part of that written program is the medical evaluation that's conducted, and then the fit testing that's conducted. So all of that, the first key component of having your folks wear respirators such as the N95, as you see at the bottom corner there, is to create the respiratory protection program and then have the medical evaluation, the fit testing, and the procedures all fall under that. Another key component of the respiratory protection standard is training on that specific standard and precisely what and how they use their respirators correctly. So some considerations, because as I said, this has been a pretty significant change in long-term care, and therefore there's been a number of folks that have needed to get their respiratory protection programs up and running. One thing I do want to call out here is we know that during the pandemic, there were a number of folks that were struggling finding N95s, and so OSHA had and CDC had allowed for a reuse to optimize use of your respirators. They did in May 2021 publish on their website, CDC, that they were rolling back that allowance. Now, that being said, if there's a significant issue with you getting N95 respirators, there's always good faith effort. So you do want to make sure you're documenting what you're doing and what challenges you're having. But as of May 2021, they are really rolling back the allowance to consider and continue using your N95 respirators. There's also another great tool. The CDC has a PPE burn rate calculator. So I encourage you guys to check that out if you're trying to figure out how much PPE to order, how many N95s do you need. This calculator here provides and does the calculations for you. And there also has been some discussion over the pandemic of using our traditional elastomeric half-face respirators in healthcare as well, especially for aerosol generating procedures. So as you see the bottom right hand, that's what we call an elastomeric half mask respirator. And so long as you have a proper source control for that exhalation valve, that is also something that you may want to consider. So this is a frequently cited OSHA violations in healthcare during COVID. Unfortunately, they publish their findings about yearly. So this was October 2019 through September 2020. So perhaps shortly enough, we'll get our new numbers here. But I wanted to just clarify and show that respirator protection still remains by far the top violation under OSHA. And then we have other bloodborne pathogens, hazard communication that follow as well. All right, so the next component of the COVID plan under the emergency temporary standard is creating a disinfection and cleaning and disinfection policy. And again, what's OSHA doing, so they're not changing and revising their standard every 10 minutes, is they're incorporating other governmental guidance documents and standards into their documents. So on that note, they are cross-referencing CDC when it comes to proper cleaning and disinfection in your healthcare facility. So one of the documents is the infection prevention and control, and that goes into proper cleaning and disinfection. I can talk about creating and cleaning and disinfecting a facility for 3-4 days. I have about 5 minutes to talk about it, but it is a very significant component of any program. And also, I just want to share that we know that CDC did make the pronouncement a number of months ago that cleaning, that surface contamination is less of a potential cross-contamination opportunity than originally thought, but it is still an opportunity. It is still a focus of any COVID plan. And really, the focus for healthcare has not changed. It's about cleaning, it's about disinfecting, but making sure that you're following proper procedures and understanding that cleaning and disinfecting, it's a two-step process, and it needs to be in adherence with the CDC guidelines. The other document they cross-reference, OSHA, is the CDC cleaning and disinfecting guidance that was updated in April 2021. And that's referenced more so for the folks that are perhaps outside of those patient areas. So not much real information in the emergency temporary standard surrounding their cleaning and disinfection guidance. They're cross-referencing CDC and ensuring that you're adhering to that. Also cross-reference List N, which I'm sure at this point everybody knows what List N is. And List N is going to include all of the disinfectants that are used and approved against SARS-CoV-2. There was an expedited review because of the pandemic. They did cease that review in April of 2021. So that's more for those folks that were the manufacturers that were looking to get their chemicals on the list. But we have about 500 to 600 chemicals on the list last time I checked, and you should not be using any disinfectant in your healthcare facility that is not on the list. So in short, having a comprehensive cleaning and disinfection policy in place in line with CDC guidelines is part of your comprehensive emergency temporary standard. And these are all the components of what a cleaning and disinfection procedure should look like. One thing I did want to briefly mention is validation of cleanliness. And one of the other things that I do is I run the Maryland Patient Safety Center Clean Collaborative for long-term care facilities. And that's a key component of our collaborative. We've been doing it for 2 years, and perhaps some folks on the call are part of that collaborative. But what we do is we provide, through no cost to the facility, an ATP monitor from our sponsor, and then they collect readings and validate cleanliness, and we're collecting that data, and hopefully through behavioral changes and education and training, we see, and proper validation of your data, we see those numbers going down. So cleanliness and validating that is so important. One, just to see and validate that you are cleaning appropriately, but it's also a great assurance and confidence builder for your staff, for your residents, for your visitors, that you not only are cleaning, but you are validating that cleanliness, and you are doing it through quantified data with ATP monitoring. All right, another component of the emergency temporary standard, ventilation and filtration modifications. And this is a big one in the sense of challenges and of cost. So in short, what OSHA is recommending, and they do cross-reference ASHRAE, which is one of the most well and respected trade associations out there surrounding heating, refrigeration, and air conditioning. And the ventilation, basically there's a number of provisions about how to enhance. So we know that there is a potential airborne nature to SARS-CoV-2. We know it's droplet precaution primarily, but there is that recognition it can be aerosolized for a period of time, and that's why ventilation and filtration are a key component of an emergency temporary standard. So in short, increasing ventilation. So the amount, and this is directly from the emergency temporary standard, the amount of outside air circulated through its HVAC system and the number of air changes per hour are maximized. So they don't provide a specific number, but you want to make sure that it is air changes per hour are maximized. What ASHRAE recommends is from an average of 1 to 2 air changes per hour, more so in a traditional type of office space, for example, up to 4 to 8. So I'm sure if I have any facility engineers on the call, they are shaking there because the cost benefit analysis of energy efficiency and of these increased ventilation requirements are at potentially at odds with each other. All intake ports are provided. Outside air are cleaned, maintained, and cleared. So again, part of your increasing ventilation. And then the other component is improving air filtration. Changing out your filters per manufacturer's instructions, doing your inspections to make sure you have optimal performance and function of your systems, and upgrading filtration to a MERV 13 rating if possible, or higher if possible. So this, again, it's going to depend. Retrofitting a currently existing HVAC system can be challenging. So it is all referenced if possible, if possible. Again, make your good faith efforts and document what you're doing. And that will be better than not documenting and not making good faith efforts. But improving filtration and ventilation really is the key to your modifications. And again, we've been working with a number of long-term care facilities in Maryland, helping them with supplemental air filtration, looking at different technologies and putting a procedure in place. One thing I do want to mention that this is all based on setting these requirements if you have ownership authority over your HVAC system. If you do not, and I sat through a webinar on this last week, if you do not, then that's going to be a little bit more of a challenge. But what the requirement in the OSHA emergency temporary standard states is that if you have authority over the HVAC system, then this is what you need to do. So that's where we are at right now. And so just real briefly, because I know that you are getting inundated with different new technologies. This is the greatest and latest thing. You need to purchase this great technology for only $30,000 and you will have clean air. So again, I want to go back to ASHRAE and go back to OSHA. It's about increasing ventilation and improving air filtration. That is the core, that is the key. There are some interesting technologies, bipolar ionization, photocatalytic oxidation, different types of UV lights that can be helpful. However, make sure if you are interested in these technologies that you get the right information from the manufacturer. You want real world data and proof of procedure and that they are doing what they're saying they're doing. So bipolar ionization has received a lot of news over the past month, a year and a half, as well as photocatalytic oxidation. On the bottom right-hand side, supplemental air filtration, good old HEPA filter, couple $100 you can find for smaller type areas. And that's going to provide some of that additional filtration if your retrofitting of your systems is perhaps not possible or just impractical. All right on time here, moving on to administrative controls. So also part of a comprehensive emergency temporary standard COVID-19 plan are the administrative controls. So one would of course be health screening. Employees must be screened prior to the work shift. Internal log to document positives, that's another really important component of this plan, is that you must have now a log where you're documenting any positive cases and how you are determining that. As far as how you screen your employees, they are allowing for self-monitoring at home before you report to work. You can station someone at an entrance and then they ask the health screening questions as they approach. You can ensure that you have blocked off all other but one exit where you have someone stationed. Whatever the case may be, whatever you feel comfortable, that is the appropriate procedure. There is no requirement under the emergency temporary standard for taking people's temperatures, for example. Okay, now that can be part of it, but as far as mandating that someone's at the door taking temperatures, it is not part of it, but it is a part of a traditional COVID-19 screening. Continuing on with just valuable resources that I do want to share with you, and obviously I don't expect we're all going to be experts in the emergency temporary standard after my presentation. So really my goal is to share an overview and to direct you towards valuable resources to help you with this. This is one that was published by OSHA, and these are pretty new and really valuable. So this is a guidance for employees. So a scenario 1 where the employee is positive, scenario 2 where they're suspected and experiencing symptoms, scenario 3 where they're getting close in contact with someone, and it provides a nice flow chart as to notification and then also to returning to work policies and procedures. So again, I put the website there down at the bottom for you to use. And again, this is guidance for if an employee is potentially exposed or positive, what procedures follow. Another great flowchart, which would be for employer notification. So once the employee is notifies the employer that they're positive, or that they have symptoms, or that they've been in close contact with someone that's positive, then again, there's a nice flowchart there under OSHA to help you determine procedures, record keeping, and return to work policies. Also part of your emergency temporary standard is reporting to OSHA. So determining first if it is work related, and then under the emergency temporary standards, employers are required to report a COVID-19 inpatient hospitalization that occurs anytime after the work-related incident. So they're sort of erring on the side of caution, and you'll be notifying them in those circumstances. As far as the timeframes, if there is a COVID fatality, it's with 8 hours of notification, and the same thing with hospitalization. It's within 24 hours, not of when that individual is hospitalized, but when you were notified of that, because you may not know for a day or two, perhaps. So that's the specifics regarding reporting to OSHA. So there is a reporting component to OSHA under their 300 log. And the next essential component of your administrative controls is employee training, obviously. A program and a plan is only as good as its implementation. And so the training is a key component of that. Making sure your employees understand what is the emergency temporary standard, what is the COVID plan, and what does it include. Understanding the background, the potential exposures, what they do, and determining what their potential exposure is, how can they protect themselves, and basically an overview of the COVID-19 workplace policies and procedures that we've been talking about. Also part of any comprehensive training, determining those well-defined areas if that exemption is going to apply, and making sure that your workers know what policies and procedures you have in place and how they can access them. And that's all under occupational safety and health, that your employees have, quote, the right to know, and therefore all programs need to be made readily available to them. And then just to finish up, additional administrative controls, vaccination procedures also need to be part of the plan. The authorization that they will have paid leave or time off for the vaccine, and if they have any side effects, will allow time for that. So again, there's some really valuable language. OSHA has a number of resources that provide some language and help you put together these programs. Anti-retaliation measures, as we already talked about, language assuring your workers there will be no retaliation if they make a complaint surrounding COVID-19 protections in the workplace. And of course, those record-keeping requirements that we've been talking about throughout. So again, like I said, it's a nice way to think about it, whether your PPE and your standard and transmission-based precautions are in place, your engineering controls, and your administrative controls. So if you sort of put it in those 3 buckets, I feel like it's a little bit more manageable to figure out how best to adhere to it and implement your program. All right, so finishing up with some more details about the program and the emergency temporary standard by when you must comply. I'm sure many of you already know this. The date has already passed. So this was initially published, and then it was 14 days from when it was published on June 21st, where most of the requirements were already required. And then 30 days after that, which was July 21st, obviously both have passed. And that was the physical barriers, ventilation, and training requirements. Now, obviously, this is a pretty onerous standard for healthcare facilities. And based on the polling, it sounds like most of you already have a program in place, which of course you would as a long-term care facility. But it's really important that for those folks that said that they have a plan, that you tweak that plan and make it more specific to COVID, because under the emergency temporary standard, they're not just dealing with infectious disease, but they're talking about COVID in particular. So there's a number of COVID specific procedures and components that you need to make sure are incorporated into your infectious disease plan. So with that, there's a number of trade associations, a number of organizations that have had asked for extension of the comment period, which was granted. And so that we do have some time to still provide our comments from the industry to OSHA, and that is the website where you can provide your comments. All right, so what does an inspection look like? Again, there is I shared it earlier, there was an OSHA directive that was published on June 28th of 2021. And that really is for the OSHA inspectors, for them to have some sort of idea, a map of how they're going to conduct an inspection. So it's valuable, it really is for the inspectors, but anyone who may be inspected is also able to view that information. So that's really valuable. That's where I got this. What does an inspection look like? They'll meet with the safety coordinator, which I have not noted is a part of creating a COVID plan. You have to have a safety coordinator and responsible parties. So they'll sit down with the coordinator, they'll gather as much information about their policies, about their processes, procedures. They'll ask for copies of their COVID-19 prevention plan and all their other programs. And then they'll also look at your hazard assessment and your results for that. And then based on that, they'll then go ahead and do a facility tour, looking at all those components that are part of your program: personal protective equipment, administrative controls, and engineering controls, as I was just talking about. So that's what an inspection looks like. As far as what enforcement looks like, here's the directive that I was just telling you guys about. And this is the reference and the resource for that. So the National Emphasis Program that was updated in July, that's all part of this directive and how we're enforcing, focusing on protections for workers who are unvaccinated or at risk. So that's really important. The OSHA directive specifically focuses on those folks that are unvaccinated or at risk. So keeping that in mind when you're talking about your, if you have a vaccinated employee, but there's an at-risk vaccinated employee, OSHA considers them in the unvaccinated group because they're at risk. So keep that in mind. Now, there is reduced enforcement discretion for noncompliance with the respiratory protection standard because of the nuances to that, ensuring workers are protected from retaliation. And one other component here is recognizing good faith. And I know I made that mention when I talked about the respiratory protection program, but they do also highlight that for the OSHA inspectors. If you, as a facility, have made a good faith effort to implement an emergency temporary standard, that will be taken into account. So again, putting my legal hat on, documentation, validation, and ensuring that you're making those efforts would all be valuable towards any enforcement action that may occur. But that being said, we're talking about all different types. We're talking about OSHA regulations and emergency temporary standard, but just to step back for a minute and keep in mind that before and after this emergency temporary standard was published, we as employers are still required to protect our employees. and they call that the general duty clause. So that's what we call the catch-all, to catch all of those potential issues during their workplace that were hazardous or potentially caused harm. So OSHA is already fining employers under the general duty clause. There are other standards, as we briefly talked about: personal protective equipment, bloodborne pathogen, hazard communication. Again, this is the opportunity to ensure that your OSHA programs are in place and they're being adhered to, because OSHA's national emphasis program is going to be enhanced over the next several months, and they will be potentially knocking at your door. As far as the fines, they are significant. So we're looking at, for a serious violation, $13,000 per day for failure to abate after July 21st, which is when we know the rule kicks in full. If it's a knowing or willful violation, they could say you can make it 10 times that amount, which is why we jumped all the way up there to $136,000. So no doubt the fines are severe and significant. And this is another, just as far as enforcement, this is from the Nursing Home Inspect website, which I'm sure you're familiar with that, but they also have a number of enforcement actions surrounding infection-related deficiencies. Now, this is not just over the pandemic, this is actually over several years. I did sanitize the nursing homes there. I'm not gonna call anybody out today, but there's significant monies and significant enforcement actions surrounding infection-related deficiencies in particular. So that's good to keep in mind. All right, so I always like to end my presentations with a call to action to help you to figure out what you can do now. First, review your existing infectious disease and response plan. And like I said earlier, make sure that if there are any COVID-specific provisions, that those are added, and then determining any gaps in the plan. Again, a traditional infectious disease plan you had a year or two ago before the pandemic is not going to have all the components that this emergency temporary standard is going to require. So implement or revise your facility COVID-19 plan, review your current OSHA programs and your current OSHA procedures, make sure you're in compliance there. If you do not have an environmental hygiene, cleaning, disinfection program, implement one, and ensure you're training all of your folks. So as I promised, here is a list of resources from the Occupational Safety and Health Administration. And again, they have a number of resources available for you to use. And of course, we are also available to help answer any questions, to guide you through this. And as I shared earlier, that is my contact information and that is my email. Please feel free to use that. So with that, I think I will pass it back off to Sarah. Oh, I did have one more polling question. Let me go ahead and ask this polling question, and then we can go ahead and take any questions. All right, so what are your biggest challenges when implementing the plan requirements? Now that I know that many of you do have a plan in place, is it conducting the hazard assessment to determine the risk, time to create and refine the plan, adequate training to confirm compliance, or enforcement of adherence to the plan? And I know maybe they all won't fit under one answer, but just, I guess, your biggest challenge of those that are there for you.
Shari, while people are filling out the poll, thank you so much for joining us. That was an incredible amount of information in such a short period of time.
Yes.
With slides that were very easy to understand and read. Is your slide deck something that you're willing to share with the callers today?
Most definitely, I'd be happy to.
Great, yeah, if you could send that to me, and then I will include a link to the slides as well when I include the recording.
Okay.
To pair with that. So yeah, I know we had a question for that in the chat.
All right, so as far as the polling question, it looks like time to create, refine the plan. Exactly, I feel your pain there. And I think also, you know, adequate training always remains an issue, and it's not just about training one time, but it's about retraining and doing refresher training. So making sure you're keeping up with that. And, you know, enforcement, I think, is always going to be a challenge, because, you know, who's going to be responsible for ensuring they're meeting that requirement. So thank you again for your input on the polls. I really appreciate it. And yeah, Sarah, I guess I'm ready for any questions that have come through.
Yeah, great. We have had actually a lot of questions come through, which is wonderful. We'll try to get to as many as of these as we can in the next 7 minutes or so. Do you want to run through the chat box, or would you like me to read off the questions to you? What would be easier?
Yeah, if you can read off the questions that
Sure. Sure. So if we have 100% staff vaccination and vaccination policy as a condition of employment, would exemption apply?
So you have 100% vaccination in the circumstance where if you have 100% vaccination, there is no understanding that anyone who is potentially infected will come in, and you have no shared space, then there may well be an exemption for that. But it's not just about having everybody vaccinated, as I highlighted earlier, but it's about being vaccinated and having a space that will be protected, and that no one is coming in and out of that space that potentially is impacted, and that it's a space that is defined. So that is only having them fully vaccinated, only one component to meet that exemption.
Great. And can you just remind us all when the rule has taken an effect?
So yeah, so the rule, and it's kind of crazy to say that the rule took effect basically the day it was published, because under regulatory law, it's an emergency temporary standard, has not gone through the full rulemaking process. So it went into effect on June 21st, the day that it was published. Then most components went into effect July 6th, and then 30 days after that, which was July 21st, the physical distancing, the training, and the engineering controls were mandated, ventilation. So it was sort of trickled in, but as of today, August 9th, it is in full effect, despite the fact that we're still allowing for public comments on it. So it is kind of ironic and crazy that the rules being implemented and you're potentially enforced, and they still are allowing for comment period. That brings up another really important point, Sarah, which is this is an emergency temporary standard, which means it's set to expire in 6 months. And I want to make sure that that's clear. However, that being said, generally what happens in these circumstances, not always, I can't see the future, but they're in the midst of looking to make this a permanent. So they're create the emergency temporary standard, but then at the end of the 6 months, it rolls into a permanent standard. And in light of the way that the current pandemic is going, I would not be very surprised if it did not. I would be very surprised if it did not become permanent. There's already been an infectious disease program that has been introduced by OSHA 10 years ago that never made it through the regulatory process, but I know the current administration is considering re-upping that to having a more comprehensive infectious disease program as a permanent rule going forward.
Great, thanks, Shari. So is a mini respirator program required if you have a full program?
I'm sorry, I lost you with the dog. The mini respirator program, what?
Required if you have a full program?
Good question. So it's only required if you're going to put or allow your workers to be in a circumstance under the mini RPP. So if you already have a respiratory protection program and everyone falls under that, then you do not have to have a mini program. The program is only in the case where you have a employee who is not in a COVID positive circumstance where they're allowed to wear a face mask, but they want to wear a respirator, or you as an employer want them to wear a respirator. That's the only circumstance where that applies. So if you don't have that circumstance, the answer is no, you don't have to have a mini respirator program in place.
And is the RPS a requirement for assisted living as well as long-term care?
The RPP, the respiratory protection program?
Yes.
Yes, in any circumstance where they're going to be required to wear a respirator, and in certain locations of an assisted living facility, that would be the case. It's going to be less so than in a nursing home, but that would be the case. Then they generally do have to have a program in place.
And you talked about the MERV rating, that the 13 is best, and that chart was really helpful. But is it an absolute requirement for facilities, or is it just recommended?
So yeah, really good question. Again, that's what the language says in the regulation is if possible. And that's really important language for that exact reason, because ideally we do want a MERV 13 filter, up to a 16, but to retrofit a system that is just already allowing a MERV 8 filter, for example, and to put a MERV 13 or 16 on there, as the facility folks know, can actually create very significant and severe unintended consequences, even collapsing the ductwork that I've spoken to mechanical engineers about. So that's the answer. The answer is if possible. So if that's something you can't do because you have an old system, you can't be retrofitted, again, it goes back to good faith efforts and documenting what you can do and the limitations of what you can't do.
Absolutely. Do you have any recommendations to communicate our respiratory plan to outside employers or employees working in the nursing home? And what documentation is required regarding this communication?
Yes, thank you. That's another, it's hard to get it all in an hour of everything I wanted to cover. So I'm glad someone brought that up. It brings up a couple of important points. So first of all, just under general liability, when you have a guest, a visitor, a contractor coming into your facilities, you have a responsibility to notify them of the procedures you have in place. So I would definitely suggest putting together a form as part of your emergency temporary standard that clarifies and defines the documentation for any third party coming on site, like a contractor. So that should be part of your plan and you should be documenting it. That also brings up another important point, Sarah, which is under the emergency temporary standard of OSHA. If you have a multi-employer work site, so say, you have your in-house folks, but maybe you outsource food services or outsource environmental services, then under the plan, there's requirements that you notify those other employers of potential exposure to your employees, for example. So, having multi-employers and having documentation for your contractors coming in, your vendors, that's all part of this robust program that you're creating.
Great, thank you. How much time is required to provide pay for vaccine side effects? Can you clarify that?
Yeah, I saw language in there. I would have to pull it up, and I'm happy to do that after the call. I don't have the specific number right in front of me right now, but I know I think it was like 2 weeks or something, if I remember correctly, because we just put a plan together for a client, and I feel like that was the number, but I don't quote me on that. I need to check, but there is a time frame and there's a monetary allowance for if you have someone who's sick or getting vaccinated and having side effects. There are different allowances and provisions. It's very specific in there, and I'm happy to follow up and send that to you after.
Great, Shari. We have 2 more questions here. I know it's after 2, so is it okay to ask those? We have a clarification question here that many of us had a COVID-19 plan we put into place prior to the OSHA requirements, but this OSHA plan is in addition to what might be our regular plan we had in place, correct, to address these specific areas?
That is exactly correct. So that's what I've been saying, that you may already have an infectious disease and prevention plan in place. I would imagine many of you do. But that is either going to need to be tweaked to include it, and then you revise it and define it as a COVID-19 plan, or you tweak it and include it in the title as well. But that is correct. Again, you guys already had it. So whether you need to tweak the current plan you have and incorporate COVID-19, but what you can't do is use the plan you had 2 years ago and just presume that it's going to cover what we're dealing with now, because it's not. So there's very specific COVID components to it that need to be integrated into your current plan if that's what you're using.
Great. And then the last question here that we have is around the hot topics, everybody's favorite, on face masks. And so are fully vaccinated employees exempt from wearing a face mask at work unless it is a county or state requirement, or if they are deemed to be at risk because other people in the workplace are not vaccinated?
Right. I'm gonna just pull this up. I know it's over time, but it's really important to know the language. So the exemption that they're asking about is in a well-defined area. That was the terminology I was looking for. A well-defined area in any setting where there is no reasonable expectation that any person with suspected confirmed COVID will be present. So if it is a well-defined area and there is no opportunity for anyone that is suspected or confirmed, you don't have any people coming in and out. So again, my example is an assisted living facility. Unless that is a building on its own, amongst itself, on its own, and you have no shared staff and you have no potential services coming out of that, that's a very, very limited circumstance where you're going to be able to use that. So in short, unless you have a well-defined area where you know there are no persons that are suspected or confirmed, then you can use that exemption. But and you want to make sure that you're documenting all of that. But that's really how the best way to explain it and define it. So it's a limited exemption.
Okay. What are your thoughts, or what do you think of tagging staff with colors to indicate their vaccination status?
You know, I think whatever way we as employers have the ability to know who is vaccinated and who's not vaccinated, and if that's something you want to do, I honestly, personally, I'm all for that. I think, and it's what's really interesting is as when you parse through these OSHA standards, and there's a guidance document that's published for every other type of facility other than healthcare. And pretty much what it says is you're going to treat your unvaccinated workers completely differently than you're going to treat your vaccinated workers. Your unvaccinated don't need to be masked. Again, this is not healthcare. Your vaccinated do. So how are you going to be able to enforce that unless you know who is vaccinated and who is not? And so whatever system, administrative process you need to determine who is and who is not vaccinated, I am a fan of it. And I think under OSHA, it's going to kind of have to be that way, because how are you going to enforce when you don't know who's vaccinated and who's not?
Right. Well, with that, we will end our webinar for this afternoon. Shari, thank you so much for joining us. Thank you for answering all these questions. Thank you for our callers today who participated and asked questions. We appreciate all of you joining us today. Again, I will be sending out this recording and her PowerPoint slide to everybody that was on the call today. I hope everybody has a wonderful week and great rest of the day. Shari, thank you again so much.
Thank you.